Yes, we are live.
Okay. Welcome to all my dear members of White Army to this session on peripheral neuropathy by our beloved Professor Chandra Madam. It's going to be a very important topic for UGs, PGs, and even for DM residents. So let's listen to her and make the best use of this session. Over to you, Madam.
Okay, thank you. I will make a bedside approach to overall neuropathies with some important points on immune-mediated neuropathies because we see them commonly. Otherwise, everything, as you know, in neurology is an elaborate topic by itself. But this will definitely help us to approach at the bedside. Okay. So, what constitutes the peripheral nerves? All of us know that all the cranial nerves other than olfactory and optic. Olfactory and optic nerves are considered as extension of the brain. So all other cranial nerves, and these two nerves have the myelin from the oligodendroglia, whereas other cranial nerves have Schwann cell myelin. So nerves which have the myelin formed from the Schwann cell form the peripheral nerves. That is all cranial nerves other than 1 and 2, and peripheral nerves from the all the spinal roots and their peripheral extensions. Vidyama. Yeah. PPT overlap mobile mouse side la talal. Mouse I am audible, huh?
Yes, ma'am. You are clearly audible, and present slides are also okay, ma'am. Please continue.
Yes, ma'am. Audible.
Okay. So, as I told, it is the lower 10 cranial nerves and all the spinal nerves. It consists of a network of nerves that branch from the central nervous system and connect to the rest of the body. They come from the central nervous system and branch, form plexuses, roots, trunks, and connect to the all parts of the body. It is involved in both involuntary and voluntary actions, and they form 43 pairs. There are 43 pairs of these nerves, and here you can see that you have a section of the spinal cord. We have the anterior horn cell. From there, the ventral root comes in, and you have got the dorsal root with the dorsal root ganglia, and they have the sleeve of dura around it, and you can see the anterior sulcus, then posterior lateral sulcus, two sulci, and these join together to form the dorsal root, and the ventral root join together to form the common spinal nerves, and then they are linked to the sympathetic chain. Here you can see that the afferent and the efferent. See that the efferent comes from the anterior horn cells. The efferent neuron, it comes and connects to the through the axons, it connects to the motor end plate, and from the sensory endings, the afferent impulses go and they reach the dorsal root ganglion and the dorsal horn. So this is the afferent and the efferent communication of the peripheral nerves. And here you can see the various parts inside that. You can see that around an axon we have got the endoneurium, and the blood vessels are there. And a few groups of axons are covered by perineurium, and many of these fascicles are covered by epineurium. So you have got an endoneurium, around the axon an endoneurium, then you have got a perineurium and an epineurium. Inside that you have got the vascular supply and the connective tissues. And Erlanger and Glasser classification, all of us know that in our physiology textbook, we know the classification of the peripheral nerves. You have got alpha, beta, and delta, and C fibers. among alpha fibers means what? They are the most myelinated fibers. Whereas C is the unmyelinated fiber and delta is the moderately myelinated fiber. And alpha fibers, you have got 1A, 1B and group 2. And 1A alpha is the motor that contains the spindle afferents. It supplies the muscle spindle. And 1B is the Golgi tendon organ. That is also motor. And beta is the cutaneous mechanoreceptors. And A delta is the fast conducting pain fiber. And C fiber is the slow conducting pain fiber. So these are the various fibers and their classification. And here you can see that you have got the myelinated fibers, which are either motor. The motor myelinated fiber A alpha, which connects to the spindle afferents, I already told. And among the sensory fibers, you have got myelinated, thinly myelinated, and unmyelinated. The myelinated sensory fiber is A alpha and beta, and that carries the proprioceptive function. And thinly myelinated is A delta, that is fast fiber, and unmyelinated is C fiber, which is slow pain. Fast pain is A delta, slow pain is C fiber, and you have got autonomic fibers, which consists of thinly myelinated as well as unmyelinated fibers. So motor fibers are large myelinated fibers. Among sensory, proprioceptive fibers are large myelinated. Pain fibers are thinly myelinated, fast conducting, and unmyelinated C fiber. And autonomic fibers constitute thinly myelinated and unmyelinated fibers. And we know that the motor fibers has got a control over the muscle spindle, and sensory myelinated is proprioceptive, touch, vibration, position, perception, and thin myelinated fast conducting fiber is temperature and pain, and unmyelinated C fiber is pain, but it is a slow pain, and other autonomic fibers are concerned with the various autonomic functions. So this is grossly the anatomy. So now we will go to the approach. We can approach this with the symptoms, time scale, pattern, fibers affected, and other systems affected or not. So there will be a lot of symptoms with which the patient presents, and it has to be looked at the duration, the time scale, the pattern of presentation, the fibers affected, and other systems are affected or not. So we can see the symptoms. So how does the symptoms come in a peripheral nerve disease? The symptoms come from the sensory fibers. They come from the motor fibers. They come from the autonomic fibers. And these fibers may be, these symptoms may be irritative symptoms or destructive symptoms. And these symptoms may be length dependent or non-length dependent. So we have seen the various types of fibers. All of them have got positive or the irritative symptoms, negative or the destructive symptoms, and they have got length-dependent symptoms and non-length-dependent symptoms. And these symptoms are usually worse at night, and some patients report feeling of tightness and swelling in the legs when it is not there. So feeling of swelling, that is due to false sensory transmission through these sensory nerves that produce feeling that there is a swelling. But when you look at the body part, you don't find any swelling. Then the motor symptoms are also irritative or destructive, and autonomic symptoms can be referable to the parasympathetic, sympathetic, or mixed. So 3 types of fibers in the peripheral nerve is sensory, motor, and autonomic, and each one of them can produce irritative or destructive symptoms. So what are all the sensory symptoms? We will see. So what is the definition of pain? Pain is defined as a psychic adjunct of an imperative protective reflex, according to Sherrington. So psychic adjunct of an imperative protective reflex, or anything that the patient feels hurts, according to International Pain Society. Why it is defined like that? Because you know that pain can happen in the absence of painful stimuli, and pain can be absent in the presence of painful stimuli. And sometimes the pain can be experienced as a pleasure. So that all constituted by the psychic component. In some of the classes, I have told that the pain fibers ascend. They are organized in the thalamomesencephalic junction and group into sensory component, motor component, and limbic component. sensory component goes into the sensory cortex for sensory appreciation. Motor component goes into subthalamic nucleus and the motor cortex. Why? When there is a painful sensation, the body should react and remove the body part from that locations. Then only the painful stimuli is useful. For that, you have got the motor component. And what is the limbic component? Limbic component is the affective component. That only hurts. We know that that Shakespeare's story and all, you too, Brutus, because you may expect all your enemies to hurt you, but why did a friend hurt? So that aggravates the pain. That is the psychic component. So that is why the definition is psychic adjunct of an imperative protective reflex or anything that the person feels hurts. That means stimuli need not be there. And as we all know, there is no specific pain receptor. And any stimuli beyond threshold becomes pain. So you press beyond a severe degree of press, it becomes painful. You put a heat, when the heat is very severe, it becomes pain. So, and you put cold, first it is pain and then only the temperature. That is called Lewis double response. We have studied it in our physiology. So whenever a painful experience is happening, you don't know what is happening. Is it heat or pressure or cold or touch? First it is pain. And that means you protect yourself. When you remove your body part, you know it is fire. So that is called Lewis double response. First response is pain. And second response is the specific sensory stimuli. So what is paresthesia? Paresthesia is sensory perception in the absence of sensory stimuli. It is due to uninhibited small fiber activity. This happens when there is a destructive disease of the large fiber or irritative disease of the small fiber. So the patient can present with paresthesia. Secondly, patient can present with dysesthesia. Dysesthesia is altered perception of a sensory stimuli. So unlike paresthesia, you have got a stimulus, but the stimulus is perceived differently. This is called as neuronal crosstalk. The mechanism is called neuronal crosstalk, and this indicates that there is repair taking place. So when supposing a pain fiber is destroyed, and that is repaired by a temperature fiber. Whenever you give a painful stimuli, it will be appreciated as temperature. So that is dysesthesia. Yeah, a particular stimuli is there, but stimuli is misinterpreted as something else because one type of fiber is cross-talking with another type of fiber. So that indicates a person with dysesthesia is already having a repair. So he is very unlikely to be suffering from an inherited neuropathy where repair is not there. So that is the importance of differentiating these symptoms. What is hyperalgesia? Hyperalgesia is lowered threshold for sensory appreciation. So even when you go near an abscess, you start appreciating pain, even though you not touch that abscess. That is happening either by chemicals or by psychic. Chemical is slow reacting substance of anaphylaxis, substance P, and opening up of potassium channels, interleukins and inflammatory mediators. They form the chemical agents which lower the pain threshold. And psychic is previously you have experienced that when an abscess is touched, you get severe pain. So now even when the abscess is not touched, we experience pain. So that is hyperalgesia. Allodynia is pain provoked by non-painful stimuli. So just you touch and that becomes pain. This happens in some complex pain syndromes occurring in thalamic lesions, etc. And next negative symptom is numbness. Numbness is loss. So loss of sensory. So irritative symptoms in sensation may be paresthesia, dysesthesia, hyperalgesia, and allodynia. And negative symptom is numbness. Then motor, you have got a lot of irritative symptoms. One is cramp, second is contracture, pseudo-contracture, myokymia, fasciculation, fibrillation, tremors, and continuous muscle fiber activity. So what is cramp? Cramp is a painful shortening of a muscle fiber due to energy deprived state of the muscle where the person can experience cramp normally when he is exposing himself to unaccustomed exertion. or in an abnormal muscle, accustomed exertion, like mitochondrial disease, fatty acid oxidation disorders. So these are energy metabolism related disorders where cramps will come easily. You are not doing any severe work. So that is a pathological, but in normal people, when you do unaccustomed exertion, you can get it. It is a painful shortening. And if you put a EMG needle, it is electrically active. Contracture is also a painful shortening, but unlike the cramp, it never happens normally. This is always abnormal and it is electrically silent. It definitely indicates an energy deprived muscle disease like mitochondrial cytopathy, fatty acid oxidation disorder, carnitine deficiency disorders, those group of disorders. Then what is a pseudocontracture? Pseudocontracture is shortening due to involvement of the non-contractile elements of the muscle. Generally, conventionally, we call pseudocontractures as contractures. Like, for example, tendo-Achilles contracture or bony contractures. These are all not due to the contractile component of the muscle. They are due to involvement of the tendons, bones, ligaments. So that is pseudocontracture. Myokymia is a vermiform activity seen in the muscle, which is due to contiguous activating of adjoining motor units, commonly seen in acute denervation, like Guillain-Barré syndrome, or it can be seen in metabolic disorders. It can sometimes be seen in VGKC syndrome, autoimmune disorders. Then what is fasciculation? Fasciculation is spontaneous contraction of a motor unit due to haptic conduction in the terminal axon. What is that? When the anterior horn cell from that motor neurons are coming, we saw that. And when there is a dying back, you will have a motor unit which is connected to the motor fibers, muscle fibers, but it is not connected to the cell body. So what happens? When there is an afferent impulse activated, it retrograde axoplasmic flow, it travels back. But unfortunately, it will be stopped before reaching the cell body. So haptically, it comes back and stimulates the motor unit which it is supplying. That results in a visible spontaneous twitching, that is fasciculation. Fibrillation is a spontaneous activity in a single muscle fiber due to denervation hypersensitivity to the chemical environment. So this comes from a single muscle fiber. It is not due to haptic conduction in the terminal axon. It is due to the acetylcholine. Normally what happens, acetylcholine will be released at the neuromuscular junction and it will go to the postsynaptic receptors. Whereas when there is a disconnection of that muscle fiber from the motor end plate, what happens? Acetylcholine becomes smeared on the muscle fiber. So the whole muscle fiber suffers what is called denervation supersensitivity because it is not received by the corresponding receptor, but it is smeared all over. And tremors you find in peripheral nerve disease due to, that is called arrhythmic pseudo-tremor. Patients with peripheral neuropathy, when one fiber is destroyed, is a motor positive. It's an equivalent of dysesthesia, the motor. So another fiber tries to repair. So what happens? We know that in any motor activity, there is a kinetic melody. Kinetic melody is the rhythm of the motor activity for which there is an appropriate activation of agonist, antagonist, synergist, and fixator. But when the repair comes, what happens? And agonist muscle may be stabilized by an antagonist, which is not destroyed. So we will not be able to maintain posture. And when you try to maintain posture, there will be up and down vibration. But unlike the classical tremor, where it is rhythmic, repetitive movement around a fixed point, this will be arrhythmic movement. The amplitude up and down will not be predictable. So that is called pseudo-tremors that happens in faulty regeneration, and it is an equivalent of dysesthesia in the sensory structures. And you can have continuous muscle fiber activity, which is due to progressive fluctuating muscle rigidity and spasm, which you will get in some conditions like Isaac syndromes and continuous muscle fiber activity syndrome. So these are stiff person syndrome. So these are the positive features in the motor pathway. And autonomic features, you can have dry mouth, dry eyes, orthostatic dizziness, constipation, bladder symptoms, sexual dysfunction, sweating problems, discoloration of the skin. And examination will reveal orthostatic hypotension, skin changes, atrophy, dry skin, shiny skin, discolored skin, edema sometimes as the result of pseudomotor and vasomotor abnormalities. So that is the symptoms. So you have sensory symptoms, you can have motor symptoms, you can have autonomic symptoms, and those symptoms may be irritative symptoms or destructive symptoms. So we have, so patient presents with those symptoms. Based on that, we will decide, is it a sensory, is it a motor, is it autonomic, or more than one is involved. So for the first symptom, some amount of information is obtained. Next is the time scale. So is the disease acute? Is the disease subacute? And is the disease chronic? So acute, the duration is usually less than 1 month. Subacute is 1 to 3 months. And chronic is more than 3 months. So that is the time scale. And next, is the disease over a period of time continuously progressing? Or is the disease progress for some time and regressing? Or is it remitting and relapsing? So that is the time scale. So now you know you have got a patient who is having a sensory dominant problem, which is acute onset and it is regressing. Then you have only few differential diagnoses. So with the second symptom, you become little more wiser. No? Then at the bedside, we'll ask, as I said, duration, acute is 4 weeks, subacute is 48 weeks, and chronic is more than 8 weeks. And then is the pattern. So pattern of involvement. So we have picked up the time scale, we have picked up the pictures, structures involved. Then you are putting them into some patterns. So you can have a cell body pattern, which is called a neuronopathy. So is it a neuronopathy or the cell body? Cell body is involved or the nerve axon is involved. So cell body is involved or the axon is involved. That is neuronopathy versus neuropathy. So pattern may be neuronopathy person, pattern like Sjogren's disease. Then you have got some differential diagnosis only if it is a neuronopathy. If it is a neuropathy, you have got a different group of differential diagnosis. Next, is it motor? Is it sensory? Is it autonomic or mixed? So that is the second group of patterns. So these patterns recognition will narrow down your differential diagnosis. Next, is it a demyelinating disease or axonopathy? We saw that the proprioceptive fibers and motor fibers have got lot of myelin, whereas the sensory fibers and autonomic fibers are less myelin. So if it is a demyelinating disease, it will pick up only the myelinated fibers. Non-demyelinating diseases will pick up the less myelinated fibers. So that will give us a clue what is going to be the pathology. Next, after noting down all these features, is this person having an inherited disease or an acquired disease? Then is the disease metabolic disease or immune-mediated disease? So at the end of the history, these are the questions we will ask ourselves. And is this disease due to some infections like Hansen's disease? We had a session. Or is it neoplastic or paraneoplastic? Is it drugs, toxins, and compressions? And still, after all these questions and all these information gathering, 20 to 30% of the neuropathies remain cryptogenic. That means we do not know the cause. But we have to make an attempt to know the cause in all the patients, for which there is a very interesting approach that is called 3-6-10 step approach. 3-6-10 step approach. What is the 3? 3 is the 3 goals. For those 3 goals, you ask 6 questions. And if you ask 6 questions, you get 10 patterns. And this is the reference for that article. This is very useful. 3 goals, 6 questions, and 10 patterns. What are the 3 goals? We have gone through the symptoms, we have gone through the profile, and we have got the data. Now we want to, we know at the end of all this, we put them into compartments. So what is the site? What is the cause? And what is the treatment? All this should be identified with the information that is gathered. That is the goal. That is the number 3. 3 is you should know the site, you should know the cause, and you should know the treatment. What are the 6? What is that 6? You have got 6 questions. So after knowing the anatomy, after knowing probably the cause, we want to know is there a treatment. These 3 questions should be answered. For that, we ask 6 questions. What systems in the nerve are affected? Is it sensory? Is it motor? Is it autonomic? Is it mixed? Is it length dependent? Is it non-length dependent? Is it acute, subacute, relapsing, remitting? So that is the what are the parts affected? What is the distribution? Is it mononeuritis? Is it proximal? Is it distal? Is it length dependent? That is the distribution. So second question you ask is the distribution. Third question, what is the nature of sensory involvement? Is it the large fiber or the small fiber or both? And is the upper motor neuron affected in addition to the lower motor neuron? What is the time scale? Is there a history of heredity? So these are the 6 questions. So 3 goals, we want to know the site, we want to know the cause, we want to know the treatment, for which we ask 6 questions. What systems in the nerve are affected? What is the distribution? What is the nature of sensory involvement? Upper motor neuron affected or not? What is the time scale? And is there a family history? And then we get 10 patterns. If you answer these questions, we get 10 patterns. That is, a person is having a neuropathy where the proximal and the distal is equally involved. So proximal and distal symmetrical. That is one pattern. And second pattern, distal sensory. So you can get 10 patterns. So proximal and distal symmetrical means it will point to one group of differential diagnosis like CIDPs. If it is distal sensory alone, then toxin, nutritional, drugs. So that is distal sensory. That's the second pattern. Then diagnosis becomes so easy. Then asymmetrical distal with sensory. That becomes mononeuritis multiplex. So asymmetrical distal with sensory, mononeuritis multiplex, most likely Hansen's disease. That is asymmetrical distal with sensory. Then asymmetrical proximal and distal with sensory. So asymmetrical proximal and distal with sensory. So sensory is there, but weakness is there. That is again vasculitic neuropathies, entrapment neuropathies, hereditary neuropathies, tendency for pressure palsies. That is asymmetrical. So most of these asymmetrical neuropathies are mononeuritis multiplex. Based on motor fiber, sensory fiber, or all are involved, the differential diagnosis become narrow. And asymmetrical distal motor, that is again motor neuropathies. And symmetrical distal sensory with upper motor neuron. For example, subacute combined degeneration of the cord, betel deficiency, copper deficiency, HIV. So these involve the spinal cord as well as the peripheral nerve, predominantly sensory. So when you recognize the pattern, diagnosis becomes easy. And symmetrical weakness. And focal midline proximal, that is you have got midline structures are involved, spinal, paraspinal structures getting involved. Then asymmetrical with proprioceptive loss, no weakness. So it's a large myelinated sensory fiber. You have got some inherited conditions, you have got some acquired conditions like pseudotabes of diabetes, or you have got the Belmont's posterior column ataxias. You have got copper deficiency, these HIV associated ataxias. So they are asymmetrical with proprioceptive loss and with autonomic features or not. So autonomic features, generally we tell that demyelinating diseases involve proprioception and motor, and vasculitis involve the small fiber and autonomic fibers. Toxins involve the small 6 questions. You, with the data that we have already gathered, we can get to 10 patterns. And by knowing this pattern, you can fix the type of diagnosis in your patient. So next, so we have taken the history and we have gone recognized the patterns. So now let us see, there is a family history and you are thinking of an inherited neuropathy. So inherited neuropathy, absent family history does not rule out inherited neuropathy. And detailed family history and examination of family members is important because there can be variable expression and some of them have got minor features which they may say they don't have any disease. So we have to examine the family members, and signs will be more than symptoms. Most of the inherited neuropathies, these people do not know what is normal at all because they are born with a disability and they think that is the way everybody is. So they do not tell so many complaints. But when you examine, you will find lot of signs, but symptoms are less. So that is a clue. So family history may not be there. You have to examine the family members, and signs are more than symptoms. Positive symptoms do not occur. As I said, there is no dysesthesia, there is no paresthesia, there is no because there is no repair. So positive symptoms do not happen in inherited neuropathies, and most of the time they are symmetrical and long duration. So if these features are there, they point to an inherited condition. And what are the classification of hereditary motor and sensory neuropathy? Otherwise, we used to call them as Charcot-Marie-Tooth disease, peroneal muscular atrophy. Under this, we have got this old classification. Newer revised classification is based on genetics and pathology. That's a different one, but this is for bedside. So the type 1 is hypertrophic or demyelinating form, where you will have areflexia, inexcitable nerves, and significant weakness. So that is hypertrophic, where the nerves are palpable and nerve conduction is very bad. Second is the axonal form, where there is distal wasting and distal reflexes are lost. There is no uniform areflexia. Nerve conduction is not very bad, and amplitude suppression. That is the type 2 or the axonal form. Type 3 is X-limbed and it resembles the demyelinating form. But only thing, if you take history, only males become affected. Fourth is the Digerin sota. Early child becomes symptomatic. They will have severe kyphoscoliosis and they develop trigeminal neuropathies. And when you palpate the nerves, they are soft and juicy. Big nerves, but soft and juicy. That is Digerin sota. Rough sums, you have got a thick nerve, but not beaded. They will have ichthyosis. They can have RP and deafness and anosmia. That is rough sums. There is abnormality in the phytonic acid. Then you can, type 6 is peripheral neuropathy associated with spasticity. Type 7 is peripheral neuropathy with optic atrophy. Type 8 is peripheral neuropathy with retinitis pigmentosa. So this is the clinical categorization of hereditary motor sensory neuropathies. Then based on the pathology, you can call them as demyelinating. If there is a demyelinating pathology, that is the type 1. Type 1 is demyelination. And it can have an autosomal type 1, as I said, weakness, areflexia, delayed conduction, and it can be autosomal dominant, autosomal recessive, or X-linked. And second, type 2 is axonal. Again, it can be autosomal dominant, recessive, or X-linked. Then you have got the other phenotypic varieties, which I have already discussed. And you have got other neuropathies like congenital hypomyelinating neuropathy, which becomes very symptomatic in early childhood. Small children present with neuropathy. And then you have got hereditary neuropathy with tendency for pressure palsy. So slight pressure. Somewhere they go and sit, they compress themselves and they come with a mononeuritis. Say sit with cross legs for some time, they get up with a foot drop. Then they will tell, my father also felt it, or your siblings also felt it, and I have it more because I do mridangam and I played for 2 hours. So depending on how much you press your nerve, your neuropathy may be more, but family history or doing an electrophysiological evaluation showing abnormal conduction in the family members, and of course the genetic testing is useful. And currently, current latest classification clubs pattern of inheritance, genetics, and pathology. So you can have autosomal dominant and this particular gene unfolded myelin. So that becomes the newer classification. So autosomal dominant, recessive, X-linked. What is the gene loci? What is the pathology? All 3 parameters are clubbed together, and that is the way diagnosis is classified now recently. But at the bedside, we still hold on to the old classification. Then we have got the hereditary sensory neuropathies. Under hereditary sensory neuropathies, you have got a Denny Brown type, Marwan type, hereditary insensitivity to pain, and sensory autonomic neuropathies. What is the Denny-Brown type? Denny-Brown type involves both upper limb and lower limb. They develop yearly trophic ulcers and looks like the hands are diabetic, reserved fingers. That is Denny-Brown. Both upper limbs and lower limbs become affected. Whereas in Marwan's type, it is upper limb dominant. Short axons become affected. Upper limbs are symptomatic, so often mistaken as syringomyelia. And hereditary insensitivity to pain is otherwise called human pin cushions. These children do not cry when they get vaccination. They are considered very smart children. And when their teeth starts appearing, they bite their tongue and come with split tongue. And then you understand that they don't have pain at all. And they do not survive because of the minor injuries. They don't recognize and auto amputation of limbs, sepsis, and death. So that is the hereditary insensitivity to pain. And next is a sensory autonomic neuropathy. These children have poor autonomic regulation. Because of that, they have heat intolerance. So when they are young, most of the time they want to be under the tap. So we think that they are playing with water because they don't have they are poikilothermic. So they are not able to do temperature regulation. Mostly they have heat intolerance. So they stand under water, and later we will, when they grow up, we may be able to demonstrate with a high degree of suspicion that they are having orthostatic hypertension. Only when you look for it, we will find all those things. And in addition, sensory. So sensory plus autonomic. The usual clinical picture is, as a child, they were always under the tap for thermoregulation. Then what is a neuronopathy? I said the pattern you have to recognize, neuropathy, neuronopathy. So when do you think is a cell body? So non-length dependent. Length dependent means longest nerves get affected. So you call it as a neuronopathy when it is non-length dependent. So it starts in the face or starts in the upper limb. Then that is one feature of neuronopathy. Second, it is multifocal, multi-segmental, and asymmetric. So neuronopathies are non-length dependent, multifocal, multi-segmental, and asymmetric. Sensory ataxia is common. So they mostly, other than sensory impairment, they have sensory ataxia. It is both proximal and distal, and autonomic can be affected, and electrophysiological difficulty with axonopathy, because electrophysiology can be misleading. It can apparently show normal amplitudes and conduction. So electrophysiologically, it gives a false impression. Next, so it's a neuronopathy or not. So those are the features. If those features like non-length dependent, multifocal, multi-segmental, sensory, autonomic is there, then you think it's a neuronopathy. Is it demyelination or axonal? So it's not neuronopathy, it is a neuropathy. Let us imagine a neuropathy. Then how are you going to differentiate? Is it demyelinating or axonal? Demyelinating weakness is proximal more than distal. Air reflux is diffuse. Wasting comes late. Nerve conduction is very bad. They can have conduction block. EMG will show fibrillation and denervation, and recovery is generally good because only the insulation material is damaged, the axon is alive. So apparently very devastating, but recovery is better. And axonal one, distal mild, distal areflexia, wasting is early, and only distal conduction is prolonged, early denervation, and recovery is bad. So apparently axonal looks good at the bedside, but recovery is bad. Then based on the fiber type pattern, demyelination means, as I said, myelin-rich fiber. We thought what are the fibers which are rich myelin? So a demyelinating disease will involve the myelin-rich fiber. So it will be motor fibers, proprioceptive fibers, and cranial nerves 7, 9, and 10. So generally, if a person presents with the motor and proprioceptive dysfunction with 7, 9, 10 cranial nerves, then we will think maybe my patient is having a demyelinating neuropathy. Vasculitic neuropathies are nerve infarctions. They involve small fiber dominant with autonomic nervous system. 2nd, 5th, and 8th cranial nerves get involved. And toxic neuropathies pick up the small fibers, and ANS is usually spared, except some unusual like thallium. Generally, toxins spare the autonomic, but some toxins can involve the ANS. and second and the 8th cranial. The combination for toxin is small fiber, spade autonomic with second and 8th cranial. Metabolic depends on the type of disease. And infective, small mostly, that is temperature. We can see the Hansen's disease, the commonest infective neuropathies. And other system involvement. What are the other system features? They are painful punched out ulcers, painful punched out skin ulcers, purpuric spots, pigmentation, libido reticularis, that is reticulate pattern in the palms and soles. And Fabry's disease present with angiokeratoma. What is angio? Blood vessel. Keratoma, keratin. So vascular, soft chambers, which you put in the microscope, you will find blood with keratin. That is angiokeratoma is there. Then ceramide trihexosidase deficiency. That is Fabry's disease. And Hansen's changes. We have a separate session on that. So a large number of skin changes happen in Hansen's disease. Then you can have Mbbs due to toxins, lead. And then you can have ichthyosis, endocrine, metabolic, infective, rhapsome, all these produce ichthyosis. Hair changes. When there is autonomic involvement, you get hair changes. Bullous lesions are seen in conditions like porphyria, patient with neuropathy having bullous lesions. Then tongue changes. So skin, hair, nail, tongue, teeth, tonsil. So any person with a peripheral disease, we should not forget skin, hair, nail, tongue, teeth, and tonsil. So this is what my teacher, Professor K. Srinivasan, used to tell. Do not forget skin, hair, and nail, tongue, teeth, and so on. Tonsil, they'll give important clues. So you can have big tongue, you can have small tongue, you can have magenta tongue, you can have glossitis, amyloidosis, big tongue, small tongue, atrophy, like motor neuropathies, magenta tongue, beetle, glossitis, multivitamin deficiency, orange tonsil, Tangiers disease, and teeth, lead and purple. The presenting is complete. So teeth becomes altered. The pink teeth in porphyria and lead line in lead poisoning. And then what are all the short axonal neuropathies? Short axonal neuropathy means they involve the upper limb. The long axons are for the long body parts. That is the leg. Short axonal neuropathy means they start in the upper limb. So this is, so if a neuropathy starts in the upper limb, you can think of amyloidosis, organophosphorus compound poisoning, Tangiers disease, Sjogren's disease, porphyria, apart from entrapment neuropathies like carpal tunnel syndrome, hereditary neuropathy, tendency for pressure palsies, all those things. So this is taken from a textbook, angiokeratomas, showing angiokeratoma, bloody keratinized things that indicates Fabry's disease. And this is a mucosal angiokeratoma. This is how it looks in the histopathology. This is taken from the dermatology online journal. So this is RP. RP, you will find in diseases like mitochondrial disease, like NARP, neuropathy with RP. Then it is NARP. That is a mitochondrial disease. Then you have got this kind of breaking hairs that indicates arginosaxonic aciduria. This curly hair with neuropathy, giant axonal neuropathy, inherited neuropathy. You find a child with peripheral neuropathy, trophic ulcers, and the hair is like this. That is giant axonal neuropathy. This is the raindrop pigmentation. Arsenic poisoning. Commonly, arsenic is used in homeopathic medication for allergy and asthma. So some of these people indiscriminately use it for a long time when they are in waterlogged areas, and they find that this is from a patient in Alapi district where there is a Mananjeri place where it's below water level, below sea level. Asthma is very common. So there is a drug called Kabachindamani. Conventionally, these people use it and they all come with neuropathy, and you can see the line, arsenic line, Mbbs line, and you can see the raindrop pigmentation. This is from one of my early patients soon after my graduation when I started working from that place. And this is lead. Red. This is you can see the vitiligo-like patches, joint involvement, edematous skin. So this person having neuropathy, it's an autoimmune disease, scleroderma. Painful punched out ulcers. Very clear because they are infarctions, cutaneous infarctions. So painful punched out ulcers, you see, your patient is suffering from vasculitis. This is Hansen's disease. The resorption, pigmentation, and this kind of ulceration. This is autonomic involvement, depigmentation, hyperpigmentation. And this is a kind of skin lesion we find in a patient who presents like a AIDP. If you find this kind of, they are markers of internal malignancy, lymphoreticular neoplasms, they present with this kind of papules. This is a purpuric spots, again pointing to vasculitis. These are all my own patients only. Tendon xanthoma, cerebrotendinous xanthomatosis. No? This is pellagra, alcoholic patients. They can get it in the around the neck, velvety skin. That is a very typical velvety skin, pellagra. Diarrhea, dementia, dermatitis around the neck and in the limbs and sun exposed area have the velvety appearance. All my patients only. Pepper and salt skin, dermatomyositis, or these connective tissue disorders. And these are the various other skin changes. You can have palpable purpura, vitiligo, and facial rash. And these are all associated with neuropathy, means indicate acute vasculitic disorders. So this is again all the skin changes which I had already shown. And this is a patient who had hereditary neuropathy with, they have got a tendency for psoriasis. That was also a part of the neuropathy. This patient we published not, it's a very rare situation. Psoriasiform skin lesions can sometimes be genetically inherited. These are all acute conditions. You can see, look for episcleritis and as I said, psoriasiform skin lesions and various dry skins and vitiligo and brain infarction. So CNS, PNS vasculitis. So vasculitis can produce peripheral neuropathy as well as central nervous system involvement. When there is CNS, PNS, you can have pure PNS, pure CNS, CNS, PNS, and these are Behçet. Episcleritis you find in Behçet's disease. This is a Mengis-Kingi hair syndrome. They have copper metabolism abnormality, increased vascularity in the brain, and fragile hypopigmented skin. They do not. This is Sjogren-Larsen syndrome, ichthyosis, severe ichthyosis. And next we will see the nerves. What all conditions you have got neuropathy with thick skin. So we saw conditions where some pattern of skin changes happen. And thick nerves, Hansen's disease, neurofibromatosis or von Recklinghausen's disease, amyloidosis, Ruffsums, Digerin sota. Digerin sota, as I said, soft succulent. Ruffsum is hard, non-beaded. Amyloid is a large intermediate consistency. Von Recklinghausen's also intermediate consistency. Hansen's is a beaded nerve. Then you can get Kefiole spot. This is neurofibromatosis. They can present with varying types of neuropathies with involvement of CNS, without involvement of CNS, everything. Then what are all the deformities? You may find deformities of the that you can have club foot, foot drop, clawing, and scoliosis, talipus, pescavus, kyphoscoliosis, burns, and pressure sores. These are the various deformities you get. This is a clawing you find in ulnar neuropathy. That's a partial clawing. This is typical ice cone appearance in Hansen's patients. Due to bone resorption, the tip of the bones look like ice cream. So that is called ice cone appearance in typical of Hansen's disease. And this is again a mononeuritis multiplex. So both median nerve and ulnar nerve is involved. This was a patient with Hansen's disease. And this is pescavus. You find mostly in inherited neuropathies. And this is a complete clawing again, a patient with Hansen's disease. This is an inherited neuropathy, Denny Brown type, upper limb and lower limb. So a young boy having a deep trophic ulcer. And this is psoriasifum and the scleroderma. This is beetle. We cannot imagine this person presented with peripheral neuropathy and encephalopathy. And this was his skin before. When we found the beetle was very low, after 3 months, this is his original skin color. Nobody will believe this is our own patient. So this much pigmentation that became like this after beetle. Even though we say knuckle pigmentation, body pigmentation can happen. This is a excessive hair, mitochondrial disease, SERF mutation. So this is grossly the clue, 3-6-10 model. That is what we use, and use our other clues from the other system and make a brief diagnosis. So and I will deal partly with the immune-mediated neuropathies, which are very common and all of us see. So you got AIDP and the variants. That is acute inflammatory demyelinating polyneuropathy and the variants. CIDP is chronic inflammatory demyelinating polyneuropathies and variants. Motor neuropathy with multifocal conduction block. The neuropathy associated with paraproteinemia, vasculitic neuropathies, sarcoidosis, and miscellaneous radiculoplexiopathies. So what is this GB syndrome? All of us know, very, very common. There nobody would have not seen a case. So Guillain-Barré syndrome forms a heterogeneous group of disorders which presents as a monophasic illness of demyelinating, axonal or both. It may be demyelinating, it may be axonal or both. And incidence is 0.6 to 2.4 per 60,000 population. There are several variants: AIDP, Amon, Amson, Miller-Fisher, acute pan dysautonomia, acute sensory, and cranial pollen. So it can present as the classical AIDP, or it may be an acute motor axonopathy, acute motor sensory axonopathy. Miller-Fisher means ophthalmoplegia, ataxia, areflexia, or pan dysautonomia. This can sometimes be very misleading when there is a cholinergic dysautonomia. I have myself faced problem. Cholinergic dysautonomia means they will present like organophosphorus compound poisoning because of the acetylcholine released from the ganglia to the system. They will be twitching, they will be having lot of secretions, and they will be disoriented. So we will attempt to mistake them as OP compound poisoning. So unlike the OP compound poisoning, where the huge amount of atropine is to be pumped, here the absolute amount of the cholinergic neurotransmitter is not high. Only thing, it is released from their sites. So a very small dose of atropine itself will block this symptom. That is acute cholinergic dysautonomia. But of course, other investigations, CSF showing normal change, or whether it is showing a cytoalbuminuric reversal, electrophysiological changes, all those things will come later. But unless we suspect, we will miss this case. Then you can have a pure sensory and pure cranial polyneuropathy. There's a various type: AIDP, Amon, Amson, Miller-Fisher, acute pan dysautonomia, sensory type of AIDP, and cranial polyneuritis. So it's a acute monophasic immune-mediated neuropathy, most common cause for acute flaccid paralysis, and this was described by Landry and Guillain-Barré, and now it is all clubbed into one. So you call it as ascending when it is Guillain-Barré, descending when it is Landry, but now we don't use those terms. We are clubbed both. Features required for the diagnosis in studies criteria is progressive motor weakness of more than one limb and areflexia. So these are mandatory. Progressive motor weakness of more than one limb and areflexia is mandatory. And features strongly supportive of diagnosis is progressive, relatively symmetrical, and mild sensory symptoms or signs. And you can have cranial nerve involvement, and recovery is the rule. Autonomic dysfunction can be there, and absence of fever at the onset. Fever may be 1 or 2 weeks earlier. It need not be seen along with the fever, is less common. And CS, cerebrospinal fluid, will have cytoalbuminuric reversal, and electrodiagnostic criteria are there. So we have got features which when present, you doubt the diagnosis. Marked persistent asymmetry of weakness. If it is persistently asymmetrical over a long period of time, you will have to think of other conditions like vasculitic neuropathy. Persistent bladder or bowel dysfunction is not a common feature of AADP. AADP can have an acute retention because of the flaccid weakness of abdominal muscles, but soon it will recover. So persistent bladder or bowel, if it is there, you will doubt the diagnosis and look for alternate diagnosis. And bladder or bowel dysfunction at the onset, definitely you will not suspect AADP, because in bladder bowel dysfunction in AADP is due to flaccidity of the muscle. So muscle flaccidity should come first. Then only bowel. If bowel and bladder is the presenting feature, it is definitely not AADP. And more than 50 cells per cubic millimeter in the CSF. If it is there also, we will not diagnose AADP. We will have to think of HIV-associated neuropathies, chronic infective neuropathies, those kind of things you will think, brucellosis or even tuberculosis. And presence of polymorphonuclear lymphocytes in the CSF, that also you will not diagnose AADP. And sharp sensory level. So these symptoms if present, you will doubt your diagnosis. Marked persistent asymmetry, persistent bladder bowel, early bladder, more than 50 cells, presence of polymorphs and sharp sensory level. Features that do not occur, that is exposure to hexacarbon. If it is there, you will have to think of a toxic neuropathy. Abnormal porphyrin metabolism, that's an immediate differential diagnosis for urine porphyrins, potassium, hypokalemic, hyperkalemic. So these are things we always look in all patients who present with an acute paralysis. So if there is a porphyrin products are there, you are not going to call it as AADP. And if there is recent diphtheria, if they are exposed to lead, and purely sensory syndrome, it's an exclusion diagnosis, even though you have got a sensory dominant type. It's an exclusion diagnosis. And if there is botulism, poliomyelitis, myasthenia, toxic, acute severe myasthenia, toxic neuropathy, stick paralysis, all those things are self-diagnostic. And if those things are there, still we will not stick onto the diagnosis of AADP. They are imitators. Then based on the fiber type, it can be pure motor, pure sensory, or pure autonomy. As I said, pure autonomy can be mistaken as organophosphorus poisoning. And based on the topography, Miller-Fisher, if there is ophthalmoplegia and ataxia, you call it as Miller-Fisher. If there is a pharyngeal and upper limb involvement, it is called pharyngo-cervico-brachial weakness. If it produces lower limb weakness, it is called paraplegic. And you have got unusual forms, that is, they resemble plexopathies. So they are all topographic variants. Apart from the classical Amon, Amson, all those things which you have gone through, based on the topography, these are various variant forms of acute demyelinating radicular neuropathies. Then based on pathology, so based on topography, we have some group of differentials. Based on pathology, is it axonal, demyelinating? If it is axonal, it is very relevant. Electrophysiology will give us the clue, which we have gone through in the previous differentiating points, which I put in the table. Axonal winds take very long time to recover. Some of them don't recover at all. So it is a prognostic relevance. And based on the clinical course, if it is recurring, we call it as a recurrent GBS. And if it is progressing beyond 8 weeks, you call it a subacute demyelinating polyneuropathy. In the acute phase, it will resemble AADP, but it continues to progress beyond the acute period of 48 weeks, then you call it a subacute demyelinating polyneuropathy. So based on the clinical course, it may be labeled as recurrent GBS or subacute demyelinating polyneuropathy. So based on various parameters, we have got various characterization. And Miller-Fisher syndrome was described in 1956. It has got the classical triad of ophthalmoplegia, ataxia, and areflexia. Most common trigger is this jejunal infection, and you have IgG antibodies to GQ1B ganglioside. And you have got diplopia, most common initial symptom, ophthalmoplegia, then eyeballs become frozen. Pupillary dysfunction is rare but can happen, and varying degrees of drooping of eyelid. And ataxia on the 3rd or 4th day, and they have got the dysmetria. Dysmetria means broken movement. And but they do not show nystagmus or dysarthria. Dysmetria of cerebellar nature is there, but nystagmus and dysarthria is uncommon. Facial and limb paresthesia can be there. Facial and proximal muscle weakness can be there. Hyporeflexia, areflexia usually sets in by the end of first week. And immunologically, anti-GQ1B antibody is positive, and it's a minor component of the gangliosides. It blocks neurotransmitter release in the oculomotor nerves. And so this is also sometimes there is a confusion between Bickerstaff encephalitis and Miller-Fisher. So whether the disease started proximally or distally. So if it starts in the brainstem, it becomes Bickerstaff encephalitis. If you start distally, it becomes the Miller-Fisher. Management is plasma exchange, IVIG, and supportive treatment based on the symptom. For eye double vision, eye patching, corneal care, physiotherapy, gait training. Then pharyngocervical brachial weakness symptoms remain confined to the cranial nerves and the upper limb and the shoulders. Air reflux at the upper limbs, normal power and reflexes in the legs. Electrophysiological abnormalities are seen in the upper limb, and antibodies to GT1A and GD1A gangliosides. Parapyretic forms confined to the lower limb. Unlike the upper limb form, this is confined to the lower limb. Areflexia spares the upper limb. Electrophysiological changes are confined to the lower limbs, and albuminocytological reversal. And based on the topography, purely facial or oculomotor, like the upper limb form, lower limb form, Miller-Fisher form, purely facial or oculomotor forms, very focal forms, facial diplegias, pure abduction nerve, they can all be manifestation of focal atypical or demyelinating neuropathies. Then pathological variants, axonal form, patients present with the fulminant cause. As I said, axonal forms, they do not recover easily, and sometimes some of these patients remain wheelchair bound for several years. And electrophysiology, as I had already said, distal conduction will be prolonged, early denervation. And acute motor sensory axonal neuropathy, that is one classical form, AMSON. So identifying these types is of prognostic relevance. Otherwise, if you're demyelinating, ones will recover faster. So somebody will tell that why this doctor's patient did not recover and why that person recovered. So you do the electrophysiology and look for GIT infections, and so that will indicate a bad prognosis. So AMON is an axonal variant preceding GIT infection. Then you can give a guarded prognosis to your patient. Then you have got a variant forms in some regions of the world. They are related to GIT infection. The normal SNAP. So this is AMON variant in some parts of the world. We don't have to worry about that. This kind of variants are not seen in our country. And diagnostic criteria: symmetrical motor weakness in all four limbs, absence of paresthesia or sensory loss, areflexia by 1 week, and progression of weakness by 1 day to 3 weeks. Aram, hello. Avada vechamadi. Avada vechamadi. Avada vechamadi. Avada vera aru illa. So this is the different criteria for AMON. So I said the electrophysiology should be suggestive of axonal variant, and CSF will show the classical features of any ADP, abnormalities of F waves in at least 2 limbs, and motor conduction block and slowing, and normal sensory nerve potential. Then differential diagnosis: porphyria, polio, toxins, and tick paralysis. You have to look for the ticks in places where tick paralysis is prevalent. Then as ASON, it's a sensory dominant one. Acute sensory axonal. Here sensory symptoms dominate, weakness is not there, areflexia is there, and progression over 1 month, and they start improving by 2 to 4 months. That's a sensory variant. It's an explosion diagnosis, as I said. And CSF will show abnormality. Electrophysiology shows abnormalities. And autopsy studies, of course, show inflammation. Then antibodies to GD1B and GD3. And they present with ataxic neuropathies, which is relatively less, but published by our own professor from Mbbs. And then fear dysautonomia. They can present, as I said, some of them can present with features suggestive of acute organophosphorus poisoning. Other features are acute hypertension, orthostatic hypotension, incessant vomiting, diarrhea, constipation, paralytic ileus, sweating disturbance, and cardiac arrhythmias. Most of the symptoms are confined to other systems, so they can be easily missed. And these people, when their diagnosis is missed and treated as a systemic disease, they carry a high mortality. So autonomic should be suspected when the symptoms are acute onset. In a situation where an outbreak is going on, you should be very cautious. They should not be treated as a pure hypertension or pure diarrhea. They should be treated on the merit of a neuropathy. Then you can have involvement of myelinated portions of the autonomic nervous system, sympathetic white ramen communicants, vagus nerves, splanchnic nerves, and you can have you have got both unmyelinated and myelinated fibers in the autonomic system. All of them can get involved. Then the diagnostic criteria for the autonomic variant is progressive sympathetic and parasympathetic involvement, no motor sensory, areflexia, and some of the symptoms start improving, and the CSF features can be very classical like any other AIDP. So when do you call the condition as recurrent GBS? So GBS is essentially a monophasic illness. That is how we defined it. But a small person can relapse. What are the situations when they relapse? If you have used steroids, it is said that a good number of patients respond to steroid. Even though there is a controversy in literature, the truth cannot be denied that good number of patients respond to steroids. But if the steroids are used, it is said that they have a tendency to have a recurrent GBS. And yearly plasmapheresis, the antibody synthesis is not completely arrested, so they can have another relapse. And persistent infection and vigorous physiotherapy, these are postulated as causes for recurrent GBS. And is there a distinct entity of cyclical immune dysregulation? So cyclic immune dysregulation persisting in some patients can present with recurrent GBS. Or is it a evolving spectrum between AIDP to CIDP? These are questions. And unidentified triggers making the patient vulnerable. So recurrent GBS may be due to early steroids use or early plasmapheresis, or it can be due to vigorous physiotherapy, or it may be a transition phase between AIDP and CIDP, or patient may be having a cyclical disimmune state. And prognosis, extremes of age, they are poor prognosis. Too rapid progression, poor prognosis. Descending type starts in the craniobulbar and descends. They are more vulnerable to develop respiratory distress. Then autonomic involvement, respiratory and bulbar, associated hyponatremia. You can have any preceding infection, respiratory, GIT, but those who have GIT infection have goiter prone. So bad signs of bad prognostic features is all these. Small children and old people, too rapid, 24 hours he became paralyzed, descending pattern, autonomic involvement, respiratory bulbar involvement, hyponatremia, associated multiple comorbidities, and preceding GIT infections. And if the vital capacity is less than 20 ml per kg, prognosis is poor. Maximum inspiratory pressure if it is less, and reduction of 30% of vital capacity over a short period. All these are additional bad prognostic features. And there is no indication to do nerve biopsy, but if it is done, you demonstrate edema and inflammatory infiltration. And how to differentiate AIDP versus polio, especially if it is a child, painful paralysis, cranial muscles, bulbar muscles, all can be involved. Areflexia can happen. So, yeah, how are you going to differentiate? One thing, purely motor is polio. the points which resemble are cranial involvement, bulbar involvement, flaccid paralysis. But polio is purely motor. AIDP, you can demonstrate some sensory. And polio, there is a meningitis. So you can have a neck stiffness. Whereas AIDP is a demyelinating neuropathy. So you don't have neck stiffness. As polio is a meningitis, you will have cellular CSF. AIDP get a cytoalbuminuric reversal. Then polio has got a column pattern, whereas AIDP has got a nerve or root pattern. So these are, if you are able to demonstrate in a, you can demonstrate sensory features like proprioceptive involvement in AIDP, that is not demonstrable in the polio. And electrophysiology will show the various criteria, conduction block and delayed conduction, depending on demyelinating and axonal variety in AIDP, whereas in polio, nerve conduction will be normal. Then what is the chronic inflammatory demyelinating neuropathy? Clinical presentation can be highly variable. Combination of clinical and electrophysiological diagnostic criteria and supportive tests like CSF, biopsy, and MRI. More than 15 criteria are there because each one has got variable sensitivity and specificity. Still, we use the American Academy of Neurology criteria, Austin criteria. So the classification, you have got motor neuropathy with multifocal conduction block, the MATSOM variety, the distal demyelinating neuropathy with IgM paraproteinemia, and anti-MAG demyelinating neuropathy with IgA, IgG paraproteinemia, Poem syndrome, sensory predominant CIDP, demyelinating neuropathy with vasculitis, demyelinating neuropathy, systemic vasculitis. So these are some categorization. So we should be aware that CIDP can complicate HMSN. So a patient with hereditary motor sensory neuropathy is not immune to develop an acute demyelinating neuropathy. Why we should know? If the person with a familial HMSN comes with a rapidly progressing neuropathy, we should not deny him treatment, saying that he has a HMSN. So HMSN patients can get CIDP, they are not immune to CIDP. That should be recognized on its merit and treated. CIDP can complicate diabetes. So diabetic patients with neuropathy, all of them are not suffering from diabetic neuropathy. Whereas diabetic patients can suffer from CIDP. And CIDP can present with CNS involvement. So multifocal motor neuropathy, this is because it is motor, it is often mistaken as anterior console disease and always involves the more involvement of the upper limb and less involvement of the lower limb. There is a reflexes are preserved. So all these points will give a mistaken diagnosis of anterior console disease. So wrist and finger extensors are more affected. Weakness is more than wasting. Cramps, fasciculations are common. And purely axonal form of motor neuropathy has been described, which lacks demonstrable partial motor conduction block of the demyelinating type. So it is very easy to call it as MND, where we are giving a death sentence to the patient, whereas this condition is treatable. So short duration, rapid progression, electrophysiological abnormalities, even though the retained reflexes are there, you will have to suspect when the course is very short. And GM1 antibodies are there, and they respond to intravenous immunoglobulin. These are the, I am not elaborating the electrophysiology showing the conduction block, and it is showing terminals, showing various features are there. This you can go through. I am not elaborating the electrophysiology. And you have got the MATSOM variety of neuropathy, very sensory and motor, painful, hands more than angles, individual nerves are involved, stepwise progression, and slowing of conduction and temporal dispersion in electrophysiology. And it is useful in treatment can be with IVIG or prednisolone. MATSOM versus motor neuropathy multifocal conduction block. MATSOM asymmetrical, this also asymmetrical. Both are disturbed. Whereas MATSOM is sensory motor, this one is motor. That is why this is mistaken as anteroconsal disease. And both are multifocal, and you can have CSF abnormality is there in both. whereas M band GM1 antibodies may or may not be positive, and remyelinations in MADSOM, it can be seen in both conditions. Only the gross difference is motor with retained reflex, whereas here is motor sensory with depressed reflex. And we have got sensory variant of CADP, which is predominantly sensory. They present with ataxia, and weakness is not there, and usually symmetric, prolonged distal latency, symmetrical abnormality, the sensory nerve action potential. And you have got other neuropathies of long duration, monoclonal gammopathy of undetermined significance. So neuropathy associated with monoclonal gammopathy, but not necessarily myeloma. And you have got Poem syndrome. They are 75% are positive for monoclonal gammopathies, and they have other variants like multiple myeloma and Castleman syndrome where the lymph nodes are involved. And you can have myelin-associated glycoprotein monoclonal antibody associated CADPs. And you have got the American Academy of Neurology criteria for CADP, that is non-uniform slowing in 2 or more motor nerves, partial conduction block or temporal dispersion, prolonged distal latency in 2 or more motor nerves, absent or prolonged minimum F latency in 2 or more motor nerves. Then you have got clinical criteria: symmetrical proximal and distal weakness, large fibers sensory involvement, hyporeflexia or areflexia, progression more than 6 months. Whereas CSF contains elevated protein, nerve biopsy will show demyelination, remyelination, and conduction velocity may be normal or slowed. Then you have got clinical criteria, electrophysiological criteria, and CSF criteria, and MRI can show thick nerves which are enhancing with the contrast, and nerve biopsy will show demyelination. Then these are the various other supportive parameters of the American Academy of Neurology. So we do all the investigation, put these criteria, and then diagnose the condition. Must have at least the electrophysiology, that's the clinical, pathological, and electrophysiology together. And this conduction velocity in 2 or more nerves in the lower limb. So this is you can find it in the net only. Each one various points are there. I'm not elaborating all of them. These are here various electrophysiological parameters which can be taken as diagnostic of CADP. After the clinical features are there, and you do the electrophysiology. If you are doing a research, you have to use the electrophysiology criteria. Various abnormalities can be there. All of them can be taken into account to make a diagnosis of CADP. So what are points which I have already said, this is put in the table, and for various variants which you have gone through now, that is put in the summary, and this you can go through. That will be useful before our exams. So what is the role of electrophysiology? We can know uniform delay in inherited neuropathy. CADP is long duration, whereas variable degree of slowing indicates an acute neuropathy. Uniform delay in all the nerves will indicate inherited neuropathy. So that way, sometimes when you have doubt, it will help us. So this is one of our patient who is having distal weakness and wasting, and he is having bilateral facial weakness, and means these are the various other. I'm not elaborating electrophysiology because neurologists will know, and the general medical students just will need more elaboration of these points. So I'm not elaborating. You can go through this, and these are the electrophysiological patterns showing delay in the conduction velocity. So we put that and find out the conduction velocity. This is conduction block, big amplitude, small amplitude, and this is temporal dispersion, dispersed complex. And here you see distal motor latency is prolonged, and you see the distal CMAP dispersion. These are the various patterns, and F persistence, and So you have got utility in prognostication. Reversible proximal conduction block indicate good prognosis. So if the conduction block shows in the serial electrophysiology, it is showing a reversal. It indicates patient has started recovering. Inexcitable nerves and decreased CMAP amplitude indicate poor prognosis, because decreased CMAP amplitude and inexcitable nerves indicate axonal variant. So axonal variant, I said sometimes they may not recover and remain wheelchair bound. And then you have got demyelinating conduction velocity occurs mainly in the 3rd week. So if you do an early electrophysiology, it may be misleading. So we should do the electrophysiology appropriately to make a diagnosis. If it is too early, the changes will be different. So these are the various pathological features you find in CADP. In ADP, find inflammation and edema. CADP, you find onion bulbs due to demyelination and remyelination. So demyelination, remyelination, and onion bulbs indicate CADP. Then you can have vasculitic neuropathies, which will show nerve infarctions, paraneoplastic neuropathies, Poem syndrome, Castleman syndrome, where lymph node will be involved. Here you will find hepatomegaly and paraproteinemia and other monoclonal gammopathies. So this is Behçet, you find the episcleritis. And this is a blubs, sensory blubs. You find in some kind of, these are palpable purpuras. This is Poem syndrome, excessive hairiness. And you find this kind of skin lesions, edema, and psoriasiform patches. All this excessive hairiness, this kind of skin lesions, edema, all these points to the diagnosis of Poem syndrome, and you find an osteolytic lesion. So that is what it points to, monoclonal gammopathy. So hypertrichosis, telangiectasia, edema, trophic changes, organomegaly, endocrine disorders, osteolytic and sclerotic changes. So that is called Poem syndrome. And Castleman syndrome, you have got angioproliferative lymphadenopathy. So that is a neuropathy with angioproliferative lymphadenopathy. This is a test for sweating, sympathetic abnormalities. This is you can do starch-iodide, or you can starch-iodide blue, or you can do the so these sweating patterns are, you smear the patient with the starch-iodide powder, and you can say the color changes, and that pattern will say where the autonomic is involved. And this is the quantitative sweat test. That's also an autonomic function. The demyelinating ataxic distal sensory neuropathy, it has to be differentiated from CADP. Here proximal and distal, here is only distal. As the term indicates, this is distal. Both are symmetrical. This is sensory motor, this is sensory. CSF abnormalities are less, here it is more. Anti-GM1 antibody positive, IgM and K positive. Demyelination, remyelination is present, whereas here also it is present. So it is distal sensory dominant. This is distal and proximal motor dominant. Variant forms, demyelinating ataxic distal sensory neuropathy. The term based on the various phenotype and the other changes. Then we will have to do the complete workup for all the causes which we have gone through. We thought about various patterns, various causes. So depending on the case, when it is a CADP, you need more elaborate investigations for the long different diagnosis. And then all the diagnosis has to be, all the investigations will be needed based on the clinical phenotype. You have gone through the phenotype. So if you find a hypertrichosis, then only you look for myeloma. Otherwise, every case of CADP, you don't have to look for myeloma. If you find a lymphadenopathy, look for Castleman. So that kind of thing, based on the clinical picture, we will plan our investigations. We have got various antibodies that can be tested based on the clinical suspicion raised. And you can do skeletal survey, bone marrow, Benz-Jones. When the picture looks like a paraproteinemia associated syndrome, when we think like that, based on the data collected, you will plan all those investigations. And treatment is needed for symptoms and disease, for the pain, paresthesia, cramps, weakness, DVT, electrolyte abnormality, infections, ventilatory care, bowel, back, autonomic dysfunction care, They are all supportive treatment, and you can have varying drugs are there for the various symptom management and specific treatment. Treat the cause when it is present. Then plasmapheresis, immunoglobulin, immunosuppressants, and long-term medications. And take home message: immune-mediated neuropathies are treatable, so we should not miss them. They can complicate a wide variety of situations and need clinical suspicion. As I said, they can complicate diabetes, they can complicate HMSN, so we should not put them into one basket. We need a shrewd assessment of every case. That is why a neurologist needs more time to examine the case so that he can do justification to your patient. And the course of illness will decide the type. Temporal profile, ADP, CADP, relapsing, I have gone through, and associated features decide the outcome. We said that axonal type, poor outcome. Paraproteinemia, poor outcome. Castleman disease, poor outcome. So associated features decide the outcome. So points, they are treatable, so you should not miss them. They can complicate untreatable neuropathies. Underlying untreatable neuropathies may be complicated by immune-mediated neuropathy. And the course of the illness will decide what is the type. Associated features decide the outcome. And you have to, what are the situations you do? Nerve biopsy. You don't have to do nerve biopsy if you are sure it is AADP. If you are sure it is HMSN. When you are thinking of CADP, when you are thinking of Hansen's disease, and when you are thinking of rare metabolic disorders, those are the situations nerve biopsy is indicated. All neuropathies do not need nerve biopsy. So always look for family history. Smell will be affected in Ruffsum, Scheist disease, B12. Vision affected in mitochondrial disease, toxin and vasculitis. Papilledema in poems. 3, 4, 6 in Miller-Fisher's, Sjogren's, Stilbomidin poisoning and Digerin sota. 7th nerve in ADP, CADP and Hansen's disease. Deafness in vasculitis, mitochondrial disease, Ruffsum and Scheist disease. And lower cranial nerve palsy in CADP. And you can have various kinds of combination in various kind of Charcot-Marie tooth disease and upper limb onset, lower limb onset, acrodystrophic type, associated seizures, associated GIT symptoms in cerebrotendinous xanthomatosis, vitamin E deficiency neuropathies, nutritional neuropathies, celiac disease, Meniere's disease. They complicate chronic GIT symptoms and stroke-like episodes that will be seen in Fabry's, mitochondrial disease, and diabetes and vasculitic associated neuropathy. So these are the other symptoms which give some clue to the diagnosis. So they form the take-home message. And then specific treatment starts with the steroids for CADP and supplemented with the second-line immunosuppression. You can choose what you want. Azathioprine is cheap and side effects are less, but there are different levels of second-line immunosuppressants which can be used. And plasma exchange if no response. And cyclophosphamide, cyclosporin, mycophenolate, all these drugs can be used. But azathioprine is cheap, safe, and commonly used. Then we have got the monoclonal gammopathy of undetermined significance. That need not be treated as malignancy. You may have a monoclonal gammopathy, but it may not be myeloma band. And so that can be treated like CADP only. You need not treat it as malignancy. Then myelin-associated glycoprotein, if it is there, it is a poor prognostic marker. And we can use this second-line immunosuppressant rituximab, mycophenolate based on the response. So thank you. I have grossly covered an approach as well as elaborately covered the short and long duration immune-mediated neuropathies. So you can go through this once again. I think most of the points are there, but to concise it to the time limit, I rushed through. But reading it once more, it will be very useful for students. Thank you.
There are some questions by our members. The first one is, how does Gopalan syndrome present in patients?
Gopalan syndrome, burning feet syndrome.
Yes, ma'am.
It is a pantothenic acid deficiency, commonly seen with the pregnancy. It is not coming under immune-mediated neuropathy. It's a nutritional neuropathy described by our ICMR director. Commonly seen in pregnancy. So it is there is a drug called Cyancal-16. It's a pantothenic acid available, very cheap, but very difficult to get. I think I myself have seen very few cases only. Now it is not there. In the olden days, in Tamil, they used to call it as a Kandal Vadam, typically seen during pregnancy in low middle class people. Is due to deficiency of vitamin B5, pantotone plus.
Next question, ma'am. How to accurately check for timed vibrations in patients with neuropathy?
Timed vibration is very, very important because we just put the tuning fork on the angle and say vibration is perceived. That does not, that say they perceived, but you have to quantify that. You know, a normal young person below the age of 40 years will appreciate perceive vibration with a proper tuning fork, properly structured for minimum 15 seconds. And it is said that there will be a drop of 1 second per decade after the age of 40. If you are a normal person not suffering from diabetes or any other condition, it will be 1 second drop after the age of 40. So if the timed vibration shows 4 seconds, 5 seconds, just because you put the vibrator on the angle and the patient said yes, that does not mean progressively is normal. So timed vibration is mandatory to quantify the degree of involvement of vibration. If you don't do time vibration impairment can be lost. Patient says, yes, I am feeling, you take out the tuning fork.
Next question is how to differentiate acquired demyelination in a patient with the superimposed inherited neuropathy?
That is what I said. Now, we are recently also we had a patient. The patient with hereditary sensory neuropathy, they have a very slow course. As I said, they never have positive symptoms. Their signs are more tired symptoms are less. But such a patient who did not even know that he had a hereditary neuropathy suddenly got an exacerbation of sensory motor symptoms. He gets paresthesia, become disabled, rapidly when you exam, you find like all those things, power is not power is one. But did you know, did you know, you have said no, I thought, that kind of that, I always that kind of that, suddenly I am, that is such a positive, realize that their fathers different signs and symptoms that is that current go back to the baseline.
Such a vast and interesting topic, but Madam made it so simplified and summarized everything in beautiful presentation. Excellent presentation, ma'am, as usual. Well, I enjoyed a lot listening to your class, and hopefully, so many residents, medicine residents, DM neurology residents, even UGs, many UGs commenting that so far they found it very difficult to understand this particular topic, but after listening to your class, they also feel so good and made them more interesting to go through this topic. So please give us the presentation, ma'am. I'll share it in Telegram group so that everyone can again revise to the same thing. Because it was a very such a wonderful presentation. You have taken a lot of efforts to prepare, and your classes are always interesting and worth listening for each and every member. So you never disappoint any students anytime. You take all the huge efforts to make us understand any complicated topic of neurology. Thank you so much, ma'am. We are indebted and ever thankful and ever grateful to you. All your classes and all your efforts, and need your blessings. Uh, uh, Hopefully, we take forward your legacy. It may not be possible up to your extent. This much of passion for teaching, and it's impossible. But we'll try to emulate your that selflessness, and we'll try definitely as you wish, as you tell every time. The young doctors will definitely get inspired by you, and we will take forward your legacy. Ma'am. Thank you so much. You are muted, madam. You are muted.
That patient will actually just send off that yes, something and the fatherlands are big thing. But that all depends on the history is very, very important. Neurology without history laboratory alone will not help. So that is the most important lesson. In neurology. Neurology is a unique specialty where you have to spend a lot of time to really catch the flow. Anyway, thank you so much. If there are no questions, is there any question? No, then we'll stop. Any question is there? I'll answer. I think we have discussed classical cases previously. Some students have presented, but that is one aspect, and this is a collective aspect. Thank you.
Sorry. Madam has discussed the individual cases in many classes through case presentation. So I request all our members to go through them for detailed discussions on individual cases. That will be very much beneficial. So once again, so many members are thanking you, madam, in YouTube chat from all over world. There are so many students from Europe, African countries. They are attending your classes, and they are so much thankful to you. Once again, on behalf of all the members, I thank you, madam, wholeheartedly, and looking forward to learn much more from you. Thank you so much, ma'am, for your time and valuable inputs.